Good afternoon, everybody, and welcome to the Bristol Hub for Gambling Harms Research webinar. I'm Professor Sharon Collard. I'm one of the co-directors of the Hub, along with Professor Agnes Nairn, and I'm joined here today by our Hub manager, Dr. Vanessa Marshall. And we are absolutely delighted to have with us today Dr. James Close, who's an associate professor of medicine and psychology at the University of Plymouth. And James is going to talk to us about some great work he's been involved in and he's been leading on the Gambling Harms Scale Initiative. So the plan is that James is going to speak for about 40 minutes to give us a bit of time for Q&A. The webinar is recorded and will be available on the Hub's YouTube channel afterwards. I will hand it over to James to take us away for this presentation. Thanks very much, James.
Yeah, hi folks. Thanks for the introduction, Sharon. I believe you can all see my slides and everything, so I shall just kick off without further ado. So essentially this project had three discrete interlinked stages which will form the backbone of my presentation today. So essentially the first step was developing a new framework of gambling harms and recovery. Primarily in some ways that was almost as a substrate for the next stage of the project for measurement of harm and how we actually then operationalize that framework and start measuring harm. But also we wanted to do new things with this framework that hadn't been done before. We wanted to be very, very GB focused and about the communities and context here. We really wanted to bring affected others as a central part of that framework as well. And we also wanted to push it into the dimension of recovery in a much more holistic way than has been looked at historically in this sphere. So once we had this framework, that was then a sort of substrate of measurement, and then we operationalized that as the GHSI, the Gambling Harm Severity Index, and the version of the tool for affected others as well. And then finally, with this new measurement approach, we wanted to import some existing health economic approaches that have been very well used in health economics. They've been used in Australia in gambling context, but never here before. So essentially, we wanted to benchmark the GHSI against health-related quality of life. And what that enables us to do is compare gambling harms with other harmful behaviors and also with diseases and other health issues, and really helps understand that burden associated with gambling harms. It also brings existing and well-used health economic approaches into this sphere, enabling cost effectiveness of evaluations. So yeah, this is a large piece of work, lots of people involved. Sharon and the Bristol colleagues were involved in this work. Matt Brown in Australia, he was kind of a guru on these health economic methods that he's pioneered in Australia. So we were sort of importing some of his approaches into this country. But then lived experience as well was really core from the original sort of scoping of the project through to this final dissemination, and it has backboned everything we've done. So rationale for the project was really this increasing emphasis, as we know, on public health approaches to gambling. The focus is on reducing harms across the population, and that really requires a clear conceptualization of how harm manifests and who's impacted. At the same time as this sort of paradigm shift to public health approaches for gambling, there's been a shift away from these sort of historic clinical problem gambler definitions that have been sort of derived from sort of DSM sort of 80s definitions. And that's the idea that the things like the PGSI, the Problem Gambling Severity Index, which is most people here will know, but the most well-used scale in this country for measuring gambling issues. But here, there's issues with that. I think that people are beginning to recognise that the problem framing puts the onus on the individual as the problem, which can be quite stigmatising. So at the same time, as as we've had this shift away from that problem gambling, we've shifted to new measurement of harms. So in Australia, there's the so-called Langham framework of harm, and they sort of developed an instrument on the back of that, the short gambling harm screen. There's also harms items that have been put in the gambling survey for Great Britain recently by the Gambling Commission as well. But none of these are quite ideal for widespread use in this country. The SGHS is potentially Australia focused. It's also quite checklisty, doesn't really capture all the harms we might want to. The GSGB items are good for population level monitoring. They look at things like divorce and bankruptcy, but again, they're not really great for a scale use in day-to-day sort of routine, for example, clinical use. So hence why we wanted to develop a GHSI here. And also, yeah, finally, these new frameworks of measurement harms will enable more sophisticated analysis, those decrements to health-related quality of life, and align us with other public health approaches, which are particularly useful as we move to sort of NHS commissioning and so forth. So first stage was developing our new framework of harm. Um, we wanted to, reflect the experiences of people who gamble in Great Britain from various communities and contexts. So we had really purposive sampling of what we were looking at, both in terms of literature and also the people we spoke to. Really wanted to bring affected others and really wanted to start to understand recovery in a deeper way. So we did a big review of the academic literature essentially, but lived experience is core. We also did our own qualitative in-depth interviews with both lived experience and affected others to develop this framework of harm. So it's kind of a long pipeline here. I'll flag the paper to you later. I won't bore you with the details, but there's a kind of quite a long process here to essentially what spat out at the end was this. And this is a very sort of top level summary of what our framework looks like, where we have these three major harms and then the sort of three major domains of harm and then the sort of seven subdomains. So you've got resource harms, which, you have those first order financial harms, but also impacts to work and study, you know, ethical lapses, taking money without asking and betraying trust and so forth. We've got well-being harms, and not just mental well-being harms, but also, physical well-being really came up, lack of self-care, not eating properly, those kind of harms, and then relationship harms, both those close personal ones and the sort of broader social harms as well. So really some just teasing out sort of some of the top level stuff. Stigma we thought was really underrepresented in previous frameworks of harm, which kind of manifested both as kind of social stigma, people perceiving that there might be social stigma and withdrawing for their communities, but also, the society around them stigmatizing their harms and their behavior. But there's also like the self-stigma as well, that people were, those feelings of shame and so forth, which really was a big factor in the mental health issues that people were experiencing. Um, Really big interplay between all these different harms as well. There's other nuances that kind of teased out as well, like other frameworks of harm have often talked about crime and criminal behavior, but people really didn't endorse crime. They actually they talked about what are essentially criminal behavior, taking money without asking, financial abuse, and so forth. But unless police were involved, they didn't really view it or cognitize it in that way. And once we come on to measurement, that kind of has implications in terms of actually getting people to endorse questions you might be asking them. So we kind of wanted to avoid that language and get more at the sort of unethical behaviors, the way people were viewing it. And then there's social community harm. There wasn't necessarily a distinction in people's minds between what's social and what's community, and it really varied person to person. So we've kind of got this single social community domain. But yeah, that community disconnection and associated stigma was particularly noted and affected others. So we also looked at recovery as well. And really this is almost the recovery framework is almost a flip of the harm framework, and it's kind of those things that people need to do to achieve recovery. And there's obviously, there's things you'll never be able to achieve if you've been made bankrupt. You can't unbankrupt yourself. You can't win back the money you've lost. But what people are trying to achieve is, that sense of financial stability again, that re-engagement with work and activities, that rebuilding of trust, and so forth. But there's also that sort of core central domain, and that's kind of the cognitive work that people have to do to achieve those long-term goals. So yeah, recovery is really this whole life change, not just about gambling reduction and cessation. And we were sort of slightly frustrated by the academic literature, particularly here, that often was just measuring outcomes in terms of recovery about whether someone has stopped gambling or not, or whether their score on PGSI has gone essentially to zero or not. We wanted to think about it much more broadly and holistically. So yeah, it was about rebuilding mental health, relationships, self-worth, and then those recoveries of how those mechanisms of recovery as well. So that support that people always needed, whether that's formal or informal support, it was always there, but also ideas of, insight, you know, people learning about why they gambled and how to stop, the behavior change they're putting in place to change that behavior, the control they're putting in place, like avoiding certain environments, or limiting gambling on their phone. And then finally, that sort of feeling of ownership that people get, the feeling of accountability and control again, and kind of feeling like themselves again at the end. And these findings are really aligned with notions of recovery capital, which have been quite influential in areas like mental health and alcohol and drugs. So yeah, that's the finalized sort of overview of our framework of harm. But of course, like all these things, the devil's in the detail. There's a preprint available on our website here. I'll flag these again later. But essentially, you've got all the detail here, and it's really meant to be a holistic framework. So if for each area of harm here, like the resource harms, we dig into what it is, but also what it means for affected others. Where affected others might be, victims of financial abuse, for example. Also, how different communities and contexts might experience these harms in different ways. Women feeling heightened shame, ethnic minorities having specific issues related to resources as well. So the paper kind of unpacks this in much more depth. Once we have that framework, the next step was then to really operationalize it in terms of two linked measurement instruments, the GHSI for people who gamble and the one for affected others. Here, we've developed a number of measures over the years, and we really want to make sure they meet the stringent criteria that are demanded by certain agencies now. So COSMIN are like a measurement guidelines development protocols, which have been updated over the years and improved. The FDA also have quite stringent protocols as well here. And we were using some more sophisticated types of statistics that aren't always used here called rash measurement theory as well. We also wanted to do that benchmarking against utility and capability, which is essentially part three of this talk that I'll come on to shortly. So really, the methods, it was an operationalization of our lived experience work, that our qualitative interviews and so forth. But then it was, turning that framework into questions. And we did that using iterative stakeholder engagement, and then deployed, once we had the items that we'd agreed in these stakeholder workshops, we then deployed them in a large survey for psychometric validation. So in terms of that co-design process and how we produced the questions themselves, we have really strong theoretical and philosophical emphasis on contact co-development rather than a sort of more historic way of producing measures, which, you go back 20 years or even 10 years, or even people still do it now. Really common way of producing these scales was to a couple of experts that sit down, or so-called experts, academics would sit down in a room, develop, 20, 50 questions that they thought tapped all the different domains that they were interested in, throw them into a big survey, and then just see which ones psychometrically behaved the best. That's kind of been flipped around on its head a bit, and I think much more now we see content co-development. And what's satisfying about that is that in that content co-development process, you see people highlighting the sort of issues that then drop out psychometrically anyway. So you can kind of preempt the problems and preempt those kind of questions that might misbehave once you do the stats, and really get at the clean questions that people make sense to people, that they answer in meaningful ways that you expect right from the outset. So yeah, we did these multiple workshops with lived experience, with separate ones with affected others, separate ones with service providers, commissioners, and so forth, and really use that to develop items. We made a few sort of design decisions here. So we really wanted to cover aspects of harm that are subject to change, so that you can measure harm over time in a single person. So you're excluding things like bankruptcy that you can't change. Instead, we discuss financial stability. But it's worth highlighting like the new harms items that I mentioned in the gambling survey for Great Britain. Some of these fixed harms are covered there quite nicely. So in that way, we're trying to complement what's been done elsewhere. We were really keen that it was non-stigmatizing, that we avoided biases. Um, we stopped short of some of the most sensitive items, partly because of this, partly due to sort of safeguarding issues, partly because they're covered elsewhere. So suicide attempts, for example, we don't get onto that, but we do come onto thoughts of suicide. So that's really the almost the line in the sand where our measurement tool stops, is thoughts about suicide and doesn't ask about suicide attempts. And actually, suicide attempts is covered by other measures. Often we see like PGSI being used alongside Core 10, and we might imagine the GHSI being used alongside Core 10 as well. So in that way, the two instruments are kind of complementing each other. So co-development, this co-development process, there's a few things really important things that dropped out of this. We made sure the item wording was really easy to understand, softer, less judgmental. Everyone was very keen on a last 3 month recall period. They thought that the 6 months or year often used in other instruments was too long. 3 months does align more often with what's happening in drugs and alcohol spheres, for example, as well. And also that sort of right time to try and instigate change as well. Response codes are much clearer than, and I'll show you the response codes in a minute. So PGSI asks about like sometimes, most of the time, almost always. And people are like, I don't know what the difference is between most of the time and almost always. And that's really one of those examples where you see that in statistics where, there's no clarity and differentiation between most of the time and almost always. And people are telling us that. So we spent a lot of work with people making sure the response codes were really clear. Reading age, nice and low, so it can be understood by a wide cohort of people. And we spent a lot of time reducing these biases, which we know exist with things like this. So like social desirability bias, we're all guilty of that. The classic one is people go to the GP, they ask how many units of alcohol you're drinking. A GP told me they always double what everyone tells them, because people are just telling them what they think the GP wants to hear. And we know this happens with gambling and drugs and so forth. We also know denial biases exist, that people don't want to admit to themselves the truth. So we spent a lot of time looking at the academic literature on reducing these denial biases, as well as sort of co-developing this aspect as well. So we started with like a normalizing statement, which is really important here. Many people face challenges with gambling. Just saying, look, this is normal behavior really helps here. This is also something that's in the recent NICE guidance on gambling harms as well. So really non-judgmental wording, really neutral wording. And then this focus on like consequences, we say in relation to gambling, rather than asking outright this if someone thinks they have a problem or not, which the PGSI does. That's really where people are likely to say, no, I haven't got a problem. So we sort of avoid that problematic language and bypass denial in that way. So in our sort of final round of workshops with a near finalized measure, we got really strong feedback about, it's described as much softer, less stigmatizing, real improvement on tools like PGSI. People really like the non-judgmental phrasing. And like a nice quote we got was definitely better than the ones we filled out in the past. They're not as harsh statements. You don't feel like you've done something wrong, which really helped us think that we'd achieved what we'd set out to do. Um, we won't read through it now, but here it is, our signpost at the end to where you can see the tool yourself in your own time. But like I say, it starts with this normalizing statement, has nice, clear response codes, not at all, occasionally, meaning once or twice a month, sometimes once or twice a week, frequently, most days. And then, questions over the last 3 months in relation to gambling, how often have you noticed changes in your mood and feelings? And essentially, the first seven questions, the first seven items, as we sometimes call them, relate to the seven domains of harm we have, giving that nice holistic picture of the harms that someone's experiencing, the mental well-being, physical well-being, finances. And these are ordered in a very natural way that people told us they kind of, those harms cascade, that it was the mental well-being they felt first, and so on. The final three items here are like serious problems. So this is one for each major domain. So serious financial harms, serious mental health, serious relationship harms, where people are talking about financial breakdown, thinking about ending their life, relationship breakdown. So it's where, this is where someone's at crisis point where they're starting to endorse these items. Again, I'll flag at the end, but we've got three versions here to try and have something that's available for different contexts, different uses here. 10 gives you that nice full list assessment of harm, often really useful for consultation use and speaking with service providers. These are the sort of questions they're asking anyway, so it's really helpful in that way that we've had the feedback in that way that rather than asking this set of questions for, say, the PGSI and then having a separate conversation, you can combine those where you're opening up a conversation, but you're filling out the paperwork at the same time. The GHI 7, essentially, we have a version that just drops those three questions at the end. Perhaps more useful for online tool where you perhaps don't want to ask about suicide and then not be following it up. And there's ethical debates about that we can park and leave for another day. But by having a 7-item version, if you don't want to ask those tricky questions, you don't have to. And then we've also got like a 3-item, just a really brief sort of screening tool, which picks out like those salient questions, the mental health, the social relationships, and the financial worries. I actually flagged the wrong one there. So it's those basic financial worries, not the serious ones. So there's three basic problems for GP screening for triage. The sort of thing that you might put on a GP sign-up form when you ask about alcohol and so forth. So yeah, I mean it's 10 questions, score from 0 to 3. So you can produce like any instrument a score from 0 to 30. And like when you might be asking, well, what does a score of 8 mean? As a simple mental mnemonic, an average score on PGSI is pretty similar to an average score on the GHSI. Although they produce different cohorts of people, they are somewhat analogous, and I'll come on to that in a moment. There's also the instrument for affected others that works very similar way as well. But the word has been tweaked with affected others to really capture things from their perspective. So once we had this instrument, the next thing was to do some psychometric validation on it. So we did a big, very large survey with people who gamble, also people who know people who gamble as well. We threw lots and lots of different scales beyond the GHSI into this survey, existing scales of gambling harms from elsewhere, measures of well-being and capability. We also captured lots of demographic variables that you might expect as well, also things like drugs and alcohol as well. Essentially, I flagged the preprint, but the take-home message is that, we had really strong psychometric performance here. Those aspects that we spent time co-developing, like the response codes, had much better performance than alternatives like the PGSI. And our instrument had a much higher correlation with well-being, with however you measure that, scales like the Warwick Edinburgh Wellbeing Scale, for example. We were much more targeting, harm and well-being than other instruments. Yeah, and like if all this stuff fascinates you, you can check the preprint, but it all look great. One kind of powerful thing from the technique we're using, rash measurement theory, to validate our scale, is that it allows you in a way to scale the difficulty, the severity of items from like easier, the sort of less severe items to the harder items as well. So you can see how like one of the first things that people start to endorse is like those impacts on mood and feelings, and that really tallies with what people say during qualitative interviews as well. And then as harms ratchet up, it's those major well-being, financial harms, and relationship harms that come at the end. We can look at this in another way as well, from like low severity to high severity harms here. And you can start to use rash measurement theory. And I thought I'd flag this because this is almost like the next stages of this project, is you can start to do what's called like item banking and bringing lots of different scales together. So here we have the GHSI 10 alongside the Gambling Commission items. And you can see how all these items compare to each other along a single scale and start to think, instead of separate instruments, you can start to think, okay, how do all these scales relate to one another? And here you can see that a lot of those Gambling Commission items, where they're asking specifically if someone's experienced violence or abuse or committed crime or, been made bankrupt, that these are really high-end harms which are endorsed, very, very infrequently. And perhaps, those sort of things you want population level data on, but aren't going to be so useful in a day-to-day consultation approach. So yeah, there's a preprint for all this work available on the website as well if you're interested in all the psychometrics and all that stuff. So yeah, as I was saying, people, because they're so familiar with PGSI, this is a really common question. How does it relate to PGSI? On average, the scores are pretty similar. So as a shortcut, you can treat the scores interchangeably, but it's worth stressing it does not detect the same cohort as the PGSI. If you want to detect the same cohort as the PGSI, use the PGSI. But it does detect harmed individuals more specifically and sensitively by PGSI, which makes complete logical sense. PGSI is risk of harm, it's not harm itself. People are also interested in cutoffs as well, and I think we're a bit wary of cutoffs because with PGSI 8 plus just becomes a thing, and it's a scale. Why are we using that very strict definition? So cutoffs are context dependent, but if you want something familiar, those standard PGSI cutoffs are perfectly reasonable, and both logically make sense in terms of the questions, in terms of a no harm, low harm, 3 to 7 on GHSI, moderate, high harm. And we've taken the liberty of actually adding a severe 15 plus category as well here, because this is the point at which people are then endorsing those final 3 questions where people are really getting on to, crisis point essentially. And all this, you can convert between the different versions on our website. So the final part I'll talk about today is the health economic benchmarking that we did with the GHSI. So health-related quality of life, this is a really well-known approach in health and health economics. And essentially, you assess it using really well-validated instruments like the SF6D, an ICE-CAP, and they generate essentially what's called utility scores, where 0 would be death, 1 would be perfect health. No one's ever at perfect health, right? So, most populations are sitting at like 0.9 or something on this scale. But what this enables you to do once you've done this is you can do like comparative burden of disease studies. You're allowing harms from various, diseases or behaviors to be expressed in a common metric, versus depression or anxiety or opiate dependence or whatever. It also allows you to do cost effectiveness analyses as well. So essentially methods here, same sample as what I've just talked about, through lots of measures in here. For people who are sort of familiar with these sort of approaches, a really well used scale here is something called the EQ5D. We didn't use that quite specifically because it's very, very functional health, really physical questions and really not sensitive to gambling changes. And we know it's not from previous work. Which is the reason we didn't use this really well known scale. We did use the SF6D, which again is very health related. It's asking questions about mobility, self-care, activities, pain, and not all the sort of questions that really relate directly to gambling harms. But we used it because it's really well used and really well known. Our main measure, though, was this thing called ICE-CAP, which is more capability utility. It's asking about stability, attachment, autonomy, achievement and enjoyment in life. And much more the sort of things we expect to be impacted like from something like gambling. This is recommended by NICE for non-health situations such as this, capability, also social care outcomes. So analytical strategy here, essentially we imported the methods they've used in Australia, pioneered over there with Matt Brown's help. So propensity score matched basically created two scores that looked two groups of harmed, unharmed gamblers that looked very similar with respect to all the different risk factors, and then used regression models to estimate decrements in health utility and capability associated with harm severity. So how does someone's well-being go down as their harm goes up, essentially? And that's adjusted for all the sort of key confounders, smoking, drinking, comorbidities, and so forth. And we ran this lots and lots of different ways, but essentially all the answers were exactly the same. So I'll only present one set of results here. So before I show our data, I thought I'd throw on some comparator data. Otherwise, you're going to be like, what does this all mean? What do these numbers mean? In isolation, they don't mean a lot. So this is from IceCap. Our main comparator. This is some independent IceCap data here. And essentially this is the reduction. If someone sits at 1, this is how much they're being reduced from 1 down to 0 in terms of a proportional difference from various different health conditions, starting with sort of hearing loss on the left, and then through arthritis, asthma, cancer, through to opiate dependence and depression, where you get those really huge effects on someone's capability. And what you have to remember here, this is capability, right? So, people can still be quite well functioning and having good, meaningful relationships, with things that are even serious conditions like cancer, but it's where things like opiate dependence and depression, where that sense of capability is really heavily impacted. What we see with gambling harms is a really kind of similar picture. So as you ratchet through PGSI from low to medium to high risk PGSI, the harm really ratchets up to these really serious conditions as well. Very similar results with GHSI as well, and GHSI for affected others. You see this ratcheting of harm up to really, really serious impacts comparable with, major depression and opiate dependence as well. And again, we can do this by, this is the same data, but by seriousness of the condition, people with, serious, baseline heart disease through to very serious heart disease. And again, we see this ratcheting of harm from gambling as people go into sort of severe harm. It's really at the severe level of a severe health problem. We can also look at this in a linear way as well. So here we basically have someone's harm score along the bottom from 0 to 30. Like I said, the GHSI runs from 0 to 30. And as someone's score is going up, their IceCap score is going down, right? We have it here for people who gamble, for affected others. And the really notable thing there is how much affected others tracks person who gamble, how those impacts on the affected other are very, very similar to the person who gamble. Another notable thing here is that for every 1 point you go up in GHSI, you get a 1.5% decrease in well-being and capability. Very similar with affected others. For SF6D, this is a really important concept called the minimally clinically important difference. For SF6D, that's often cited to be around 3 to 5%. And what that's saying is that if your SF6D drops by around 3 to 5%, that's clinically significant. That's the sort of thing that people will notice in themselves, that clinicians will notice as well. Essentially, what this is telling us is that a 3-point difference in the GHSI, that's clinically significant. If you can change someone's scores by 3 points, it's worth doing, and they will notice it. So there's a lot of utility here for services in terms of health economic benchmarking as well, and actually using this instrument in real world services. So here, commissioning bodies, NHS England and so forth, require evidence that interventions deliver measurable improvements in quality of life relative to cost. And the usual figure that's bandied around here in this country is that for every quality adjusted life year gained, the NHS will spend 20 to 30,000 pounds on that. So essentially, if you can get someone from death, from 0 to 1 full health for a year, we as a nation, what we can afford is 20, 30,000 pounds for that. So here, from in terms of actually gambling harms and you know what this actually means, we've got some provisional service data here. A time one, when people first go into service, we've got in about 300 now, and the GHSI mean score is like 22. It's really high. These people are in crisis point when they're entering service, their suicidal thoughts, relationship breakdown, and so forth. At time two, we've got lots of data coming through, 55 at the moment, and because this is like a 3-month intervention, we'll have a really chunky number very soon. We can see at the end of this intervention, you're looking at a mean of about 10. So although people are still in, that high harm category, it's almost like approaching, the start of problem gambler status. So really, much reduced harm, very clinically significant by the end of this intervention. This maps to about 15% improvement in SF6D, ICE cap. You could start to put numbers on that, but easily worth, at the very least worth £3,000 to £5,000 per person. If you annualize it and say, actually, people are going to stay in that state for a long time, the benefits are huge from a health economic perspective and well worth, the money that's been spent here. So there's going to be longer term value here beyond that very sort of back of envelope short term calculation. And suggests that services really are delivering meaningful harm reduction and that they're cost effective. And really here, GHSI is showing that it can really support economic evaluation of services. And they're, proving to commissioning bodies that they're offering value for money, but also it could be used in like multi-arm trials, adjunctive interventions. What about if we try this? Is it worth adding this bolt on to what we're already doing, and so forth. We can also make like population level abstractions here as well. So this was kind of something originally done in Australia, and we have comparable results here. So essentially what we can do, we can take the gambling survey for Great Britain data, look at that big national data set where we know what the problem gambling rates are from the PGSI. We know that, we know what the rates of GSGB prevalence. We know that there's like 2.7% high risk gamblers. We know from our work that that decrement to well-being is, a point, about 0.2. And then we can calculate the years lost to disability, years lost to capability across, the UK. And basically these numbers are big, very substantial population level burden. One main take home message here is this sort of like paradox of burden, that it's not just those high risk individuals that are an issue, actually collectively, because people on the low risk of harm, because they're much more numerous, actually the total aggregate harm there outweighs those people who are at the high end. So I mean, you could try to put numbers on this. It's, there's a lot of caveats with doing that. But you could argue that the health opportunity cost here, how much we would be willing to spend as a country if there was a magic pill that you could just suddenly fix all these problems, we'd be, happy to spend, 10 billion using standard health economic approaches, notwithstanding impacts on affected others and so forth. So I mean, there's big problems here that really outweigh perhaps the tax revenue we're getting from gambling. So preprint available for all this on our website, again, if you want to dig into this health utility analysis more deeply. So I'll wrap things up now because I know we want time for questions. But there's a really coherent narrative across these three strands. So we've got this holistic framework of this multi-domain, relational, interlinked effects of gambling harm. We've got this co-developed, less stigmatizing instrument, much better aligned with that framework. And then we've got the health economic benchmarking, which really starts to put numbers on to what people say. What lived experience tells us is those harms are similar to other long-term conditions, other substance-based addictions as well. So I won't you don't need to pay much attention to this slide. This is like a link-heavy slide, which just shows you how we're trying to be aligned with various guidelines, how we're being aligned with recent NICE guidance, how we're aligned with Gambling Commission, NHS person-centered practices, and how we're aligning with NICE guidance for health economic benchmarking as well. Really trying to build it in a way that's fit for purpose in the current environment. For those who are interested in using the tool, like I said, we've got these different versions useful for different contexts, different versions for affected others as well, and there's a real dearth of instrumentation for affected others at the moment. So this is really novel and useful thing, particularly as we move to an environment, I think, where affected others are being paid a lot more attention to, and realizing we need to develop perhaps new services in this context. So really, we hope it can be quite Swiss Army knife in its use. Can be used for like consultation purposes, a discussion aid, and facilitating that discussion. But then, if you're capturing data, you can like benchmark change over time, both in terms of someone's individual change and showing how much better they're doing than 2 or 3 months ago. But also, you've got that surface level aggregation of data as well, which then you can use to support cost effectiveness evaluations. It can also be used for research purposes. We have other researchers deploying it currently in large surveys, which we're glad to see. Also can be used for like national survey work as well. So YGAM will be publishing their annual report soon with GHSI data in it. We're really glad to see as well. These different versions, we've got a nice, easy to use converter tool on our website that allows you to generate those health utility scores yourself and so forth. So yeah, it's all free to use. Look at the website if you're interested. We're really happy to support you as well. So do reach out to us if you're interested as well. So yeah, thanks for listening, folks. Lots of people in this work, so involved in this work. So thanks to all of them for their input also.
Thank you so much, James. Gosh, what a huge amount of work you have been leading on this really important topic. Really great to hear it. I mean, that's quite a feat to present it in under 45 minutes. So thank you so much for that. I think it's really helpful taking us through all of that. I should have said at the beginning, if you have any questions for James, please do put them in the Q&A and we can take some questions. If we can't get through them all, then James has kindly said he's happy to take them offline. But yeah, does anybody have any initial thoughts or questions? I'm going to hand over to Vanessa to be our MC for the Q&A.
Thanks, Sharon. There's no open questions at the moment, so please do feel free to put them into the Q&A, and James will answer them for you.
So I might take chair's prerogative then and ask one while everybody gets their thinking caps on and what they might like to ask. James, I was just wondering, as part of the project, obviously we've got the PGSI and other measures which are very well embedded both in research and in practice and in different practice settings. What would your kind of selling point be to people to get them to move over to the GHSI, or do you think they should continue to be used in parallel?
That's a really good question, Sharon. I think, yeah, just sort of bringing out things I touched on, I think, through the talk. I think a good reason to move away from the PGSI. I think a lot of people are frustrated with it. We did get a lot of feedback on that before we even started and throughout the project as well. People are frustrated by particularly that sort of stigmatizing language, asking the wrong sort of questions and so forth. So I think people shouldn't feel too tied to something just because it's been historically used, and it feels these measurement tools can end up feeling quite entrenched in a system, and people just do it because everyone else is doing it and everyone is used to using it. And I think we need to sort of challenge that in our minds. And we've offered nice conversion tool on our website to help people transition and think, okay, I'm familiar with these scores. This is now what a score means in a new environment, and helping people move towards new instrumentation and new ways of measuring. I think the advantage of the GHSI are several-fold. There's a non-stigmatizing language, that bypassing of various biases and denial. It's much more the sort of questions that service providers were asking anyway and wanted to get at, and the sort of thing you want to be understanding. You've then, from a sort of commissioning perspective and a managerial perspective, you've got those cost effectiveness that you can then peg onto the data you're already collecting. So I think that there's several-fold advantages to moving to a new system. And I think we're in such radical overhaul at the moment. I think it's time to move to new modes of measurement and new ways of doing things.
Thank you, James. And the questions are coming in thick and fast now, so I'll start with those ones. So the first question is about somebody wanting to develop some questions for themselves. And their question is, in an effort to gather data, we are considering using some gambling questions in our quality of life survey. Would this tool help us develop some questions?
Yeah, I mean, yeah, for sure. I mean, feel free to reach out to me. We're happy to support people. It sounds like the GHSI may be fit for purpose in that context. Without knowing more, it's hard to say, but it's very much linked to a quality of life, and it's very much that quality of life type question. So yes, 100%. Having said that, different environments, sometimes you're going to want to ask different questions as other contexts where you want to get at behaviors and cognitions of gambling, or measure something in a different context as other ways. And we're happy to have those conversations and support if people want to try and do something different.
Thank you, James. And you mentioned specificities to Great Britain. What makes this more appropriate to the GB context?
That's a good question. I think there's no reason it wouldn't be applicable to other contexts as well. The reason it is specific to the GB context is that it's locally developed and locally co-owned. The qualitative interviews, the co-design, every aspect of it. And particularly if you look at our holistic framework, we've really engaged with different communities and contexts in Great Britain. We've looked at literature as well in terms of that, everything from like specific issues we have here, like military, through to the ethnic groups we have in this country, LGBTQ communities and so forth. And we can see that there's harm manifests in specific ways in these different communities and contexts in Great Britain, perhaps differently to frameworks developed, say, in Australia, who have different groupings and so forth. So it's really pegged to that, the framework that we have and the work we've done. And we've tried to develop questions, not necessarily in a way that target those populations, but that are applicable to all these different populations in a sort of generic way, a captural way that isn't very, very specific to other contexts or foreign contexts, or slightly different. Sometimes just even slightly different changes in language can be different between, say, Australia and Great Britain. So that reflects through the work we've done to the final measurement instrument.
Thank you. And this question sort of aligns to the first two slightly. What are the key settings you would recommend signposting the GHSI to?
In terms of actual usage, I guess.
I think that's what the question is asking. Yeah. Yes, the key settings you'd recommend GSI being signposted to.
Yeah, I think in terms of usage, I think it's like design, we've designed it, and we've designed the different versions, both for affected others and people who gamble, and also different length versions to have utility for slightly different contexts. And again, this was sort of through those co-development workshops. This all came out that we would need different versions. I think starting with the shortest version, the 3-item version, that would be really useful for things like a GP sign up, where you want to know, does this a discussion? We know there's those links with harm. We know that signposting might be needed. We know that triage might be needed. So, there's that sort of context it might be used in. As you look at the sort of 7-item, that might be used in online surveys. and so forth, where maybe you don't want to touch on really serious harms, and then the 10 item becomes something very potentially very one-on-one consultation purposes where you're talking through. So bit of a Swiss Army knife that you can fold out the different blades for the different contexts you're using it in. And I think the reason for that is that we've seen like the PGSI, for example, co-opted into all these different places where it probably wasn't really initially designed. So we've really tried to think through, these are the places that measurement tools end up getting used. How do we design something that's fit for purpose in these different contexts?
Thank you, James. And a question now about the uptake of the tool. So is it being taken up by OHID, NHS gambling clinics, the third sector treatment providers, etc.? So how is that uptake going? And
uptake's been great. We've got treatment services trialing it and using it. We've had interest in the affected other instrument as well. I mean, from a national commissioning perspective, I think we've all heard different rumours in different places at different times. I think they still not sure what they're doing. I think we might end up in an environment that becomes much more democratized and much more service-led about what they're using. I don't think that's a bad thing. I think sometimes these people get frustrated with these top-down, this is what you have to use type environment, and that sort of relates to some of the things I touched on earlier, actually, and the use of, say, rash measurement theory, where we can start to put all these scales in a single severity index. And actually, that's useful in a potential future environment where people are using different things. They want to use different things in different services and different contexts. But can we then use this approach to relate people and interrelate between different measurement instruments? And that's sort of looking at the future work and where our minds are going with this, and with some funded work we currently have as well, where we're starting to look at different measurement approaches and different tools that might be needed in different ways. So yeah, we would hope that we can sort of link all this up in the future.
Thank you, James. And not surprisingly, there's a question about research. And please, could you give us some more detail about the use in GHSI for research purposes, and will it expand on the GSGB dataset for researchers looking at gambling harms, for example?
Yeah, no, I think yeah, as I was alluding to, I think it really complements the GSGB items nicely. I think the GSGB items, they were co-developed as well. They're really nice questions. I really like them. However, many of them are quite sort of fixed harms, really nice for population level monitoring, but we've kind of got more the impacts on people's day-to-day harms, also kind of spread much more into that lower level of harm as well, rather than there's just very, very serious consequences. So I think there's a nice research overlap in terms of the coverage there.
Thank you. And a practical question from the very first question where somebody was asking about gambling questions and using the tool to help develop some questions. They've asked, is it possible to connect via email? So are you happy if I share the email, your email address with the person who asked that question, so that you can link up?
Yeah, 100%. Anyone, we've developed this tool. We want people to use it. We want to help people, and we want to work with people. If there's things they want to do in the measurement space which are original or innovative, really happy to support and work with people. So yeah, reach out to us. We'll
Brilliant. So I can share the email with the person who's asked that. Brilliant. Yeah. Thanks, James. We've still got a few more minutes if there's any more questions from the audience. So please do write into the Q&A.
I think we've covered a lot of ground in those questions as well. It's really interesting just how much interest I think it has stimulated. So thank you so much, James. But as Vanessa said, if anybody's got a final burning question that they want to ask, please do so now. I guess the other thing, James, just on where you gave us the link to the website where you're hosting all the materials and the conversion. And that's going to be, is that something that you envisage kind of developing over time and kind of being a resource in its own right?
Yeah, no, that's a good question, Sharon. Yeah, that's continuing to be developed for sure. Like I say, we've got some existing work going on at the moment that Ryan, one of the researchers heavily involved in this, is leading, where we're looking at different measurement approaches that have been used, particularly in different intervention contexts when people are doing quite novel interventions. How are we seeing if these novel interventions are working? What novel approaches to measurement are there out there beyond the PGSI and so forth? So we'll have this bank of measures on there. We already have that to some extent on there. What other instrumentation is there? So we're going to sort of bring that in, bring in more of the interoperability aspects as well in that website. So yeah, there'll be various features on there developing for sure. Yeah.
I think there is just one final question before we finish. Does it need to be used with a measure of behaviour, or can it be demonstrated, or can it demonstrate a reduction in gambling behaviour?
Yeah, I think it's sorry, I'm just reading the question again. I've worked out how I can
Yeah.
Does it need to be with a measure of behavior, or can it demonstrate a reduction in gambling behavior? I think that's a good question, actually. So, you might have the PGSI is kind of a mixture of behaviors and harms, right? Whereas the GHSI is a specific harm measure. So what you're measuring is reduction in harm. If you really want to know about behavior, you could use it alongside a behavioral measure. Having said that, I mean, there is arguments that from like a psychometric perspective, these things are really, really heavily correlated all the time. And actually, if you're reducing someone's harm and you're getting a lower score in GHSI, for instance, then their behaviors are certainly changing as well at the same time. So do you always need to measure all these different things? Some people would argue actually you can infer that other bits are changing. So really, in answer to that question, it really depends on what you're trying to do. If you're just trying to see if someone's harm has reduced, I think stick with the GHSI. If you really are, say, doing a study on behavior, gambling behaviors, then you would need to measure those as well.
Thank you. Sharon, do we have time for just one final question?
I think if it's a quick one, yeah, we certainly do.
Yes, so 10 billion is a very big number, much bigger than the NHS and NIESR estimates. What challenges to 10 billion do you expect? So it's actually quite a large question, but if you can give us a succinct answer, James.
I think that's a number produced by a very different approach to the others. And it's not really a cost per se. It's as I was saying, it's kind of in a very theoretical world. If we could magically get all these people better, that's how much money in terms of health economic benefit it would garner. So it's a very different approach maybe to what has been used to generate estimates. So it's a little bit comparing apples and oranges. It would be what I would say. But these population level impacts on years lost to disability, these are very similar to what we're seeing in other contexts like Australia and New Zealand, where similar work has been done.
Fantastic. And I think that's brought us to time. Sharon or Agnes, did you want to say some final words?
Agnes, go ahead. You go ahead.
No, I just wanted to say thank you very much indeed. I know Sharon's been involved in this study. I've been very much looking forward to hearing about it, and it is certainly not disappointed. This is a really, really valuable piece of work for the whole gambling community, the gambling harms community. Thank you very much indeed for taking the time, and thanks to the audience for the fantastic questions. It's been a really, really valuable session. Thank you.
Thank you. Yeah, and as I mentioned at the beginning, it has been recorded, so there's a lot. James has taken us through such a lot. If you would like to kind of go back and listen to it again, it will be on our YouTube channel in the next few days. So it just remains me to say thank you so much, James, for sharing that research with us, and thanks, as Agnes says, to the audience. Agnes said to the audience, and yeah, we will have the video up there in the next few days if you would like to revisit it. But thank you all very much indeed, and have a good afternoon.
Yeah, thanks, folks. Bye.
Bye-bye.